Good evening, everyone. My name is Kelsey Gregory, and I will be tonight's moderator. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar, entitled The Council's Critical Care Miniseries Part 2. We are thrilled to have Dr. Hira Shafeeq presenting Caring for the Critically Ill Special Populations, Neurologically Injured, History of Substance Abuse in Obese Patients, and Dr. Dhara Shah presenting Dissociating Delirium in Pediatric Intensive Care Units. Dr. Shafeeq is a professor of pharmacy practice at the College of Pharmacy and Health Sciences at St. John's University in Queens, New York. She maintained a clinical practice site at the Trauma ICU at NASA University Medical Center. Her research interests include anticoagulation reversal in acute bleeding and health equity for trauma patients. Dr. Shah is a pediatric critical care pharmacy manager and pediatric medication safety manager at Children's Hospital in Montefiore. Please join me in welcoming our speakers. But before we get started, I'd like to share a quick few points. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you'd like to direct to the speaker, please use the question box or the chat option. The CE code for this program will be provided at the end of the program. And now I'd like to turn over the presentation to Dr. Shafeeq to get started.
Good evening, everyone. And I just want to say it's such a pleasure to be with you all. And I'm very excited to present a special critical care population presentation for caring for the critically ill complex patient population, and specifically neurologically injured ones with a history of substance abuse or obese patients. So let's get started. I just want to say that I have no conflicts of interest. Today, overall, my learning objectives for the pharmacist, I want to describe the infrequently encountered critical ill patient population, and especially neurologically injured, those with a history of substance abuse or obese patients. I want us to be able to identify risk factors for complications for these critically ill special population, define some specific pharmacokinetic and pharmacodynamic alterations in these population, and of course, outline some intervention for critical care pharmacists. When it comes to the technicians, I want really specifically, number 4, want them to also be able to specify the alternate therapy for these patient population and really state some of the pharmacokinetic and pharmacodynamic alterations. So let's first start with the neurological injury and the ICU. This is also coming from my background. I currently practice in a trauma intensive care unit, so I do see a lot of patients with traumatic brain injury. But prior to that, I did practice in a neurointensive care unit as well. So it was something that I used to encounter frequently. So here's a poll question. I kind of just wanted to get an understanding of where we all are, where do we all practice. And I wanted to know whether, have you encountered any quote unquote, neuro patients in your ICU patient population that you either treat, verify medication orders for, or a clinical pharmacist for in the past 30 days? Yes or no? All right, let's see. We have, okay, so fair amount, half say yes and half say no. So we're gonna move forward with the ones that said yes. If you have, how many neuro patients do you typically see or typically need to verify medication orders for in your ICU? Is it less than 5 a day, 5 to 10 per day, or more than 10 patients in a day? I have a feeling it's going to be closer to less than 5 a day, but I kind of wanted to see. And again, this is only for people who do see the neuro ICU patients. All right, let's see. Okay, so around 3 to 4 a day. So that's why I think, and there is a small number of people who actually see more than 10 patients a day. So we have a mix. So I think the difference really comes from, well, if you have a specialized neurological ICU, then you're definitely going to see a lot more patients. And if not, then you can see either patients that we're trying to stabilize, and then they're going to move on to a neurological a hospital with a neurological ICU. So I wanted to kind of go over what are some of the key things that you need to think through for a specific patient that's quote unquote listed as a neuro ICU patient. So neurologically injured patients in the ICU, primarily the population that you're going to see is going to be stroke patients. And even within the stroke patients, about 90% of them are ischemic stroke. So this is the stroke that we typically see, that we typically warn everyone for, with the stroke symptoms, one-sided drooping and things like that. And they typically come into the ER, and the number one thing that we do for them is evaluate them for the management of TPA, or tissue plasminogen activator. Although 90% of the patients have this ischemic stroke, it is also important to remember that about 10% of them have a hemorrhagic stroke, meaning that they are they are coming into the hospital because of stroke symptoms that are associated with a bleed rather than a blockage. I will say this, that from my practice in the neuro ICU, I used to practice in Long Island, specifically for my neuro ICU, because it's a smaller number of patient populations. They're a little bit more complicated. I used to see about most of them were hemorrhagic stroke patients. So for those of us that are practicing in the neuro ICU, our view can almost be skewed because we see bleeds a lot more than ischemia. But I wanted to remind everyone, take a moment to really remind everyone that until we really get the initial CT scan, we don't know if the symptoms of these patients are because of a ischemic stroke or a hemorrhagic stroke, and they typically present as just a stroke and the same symptoms. It's also important for us to know that a very small number of patient population that come in with ischemic stroke will end up getting the TPA alteplase in the ICU, but then that ends up having a hemorrhagic conversion, meaning that we gave them something for the management of stroke, and that medication specifically itself can cause a hemorrhage itself and then worsening. So all those things are just sort of important points to remember. You also can see vascular abnormalities. So anyone that has vascular malformation and then ends up bleeding, so that leads to a hemorrhagic stroke. And then we also have any patient that might fall and hit their head, gets into an accident and hits their head. And that's a large number of patients that you also see. So anyone with a traumatic brain injury, and that's sort of how they're classified, mostly in the ICU. So when it comes to ischemic stroke management, I did talk about it quite a bit. Just know that like most of the patients will end up, if they do qualify, will end up getting either a TPA, or they'll end up getting a mechanical thrombectomy, or some patients will end up getting both. So that's like usually typically the management for most of our patients with ischemic acute stroke. But a lot of times these decisions are being made in the ICU. Once they are, let's say there is a patient that might need to be stabilized and then moved into a different hospital for a mechanical thrombectomy. So those patients are also some patients that you can see that they're sort of like in between. So what do we need to do for these patients? A lot of times for post-stroke post-ischemic stroke management patients, whether you get the thrombectomy, like which is a machine goes in specifically to the side and gets rid of the clot, or TPA, it's important to know that we are always monitoring for bleeding complications, and that really manifests as a neurological exam. Now, what is a neurological exam can vary based on the protocol within each hospital, but most of the time it is an NIH stroke scale. Quite simply, what the nurse is doing at bedside is that every 15 minutes, so this is during the infusion of the TPA and 2 hours post-procedure or infusion. So up until, of a matter of like a total of 3 hours, this is happening, that every 15 minutes, the nurse is actually asking the patient questions, making sure that they're oriented, they know who they are, they know where they are. And if they do have an NIH stroke scale protocol, they're actually doing it every 15 minutes. And knowing that this also needs to be done every 30 minutes and then every 6 hours and then daily. And that's really important for us to know as to like how are we trying how are people trying to understand what's happening to this patient even after they've gotten their primary medication therapy. The second main thing is that a lot of times we also need to remember that patients, if they have a high blood pressure, maintaining their blood pressure to a normal, or specifically for TPA, the recommended range is for systolic blood pressure less than or equal to 180, and for diastolic less than or equal to 100 during and up to 24 hours after the procedure. So you're also monitoring blood pressure every 15 minutes and then every 30 minutes and every 6 hours. And then we just kind of follow the same protocol because it's typically for the nurse, if she's already doing a neurological exam, it's also, they can write down the vital signs every 15 minutes right along there. So where do pharmacists come in? So we come in when we need to figure out whether this patient needs a more sustained therapy with nicardipine and clevedipine, or whether or not these patients will be okay with giving an IV push of either labetalol or hydralazine. But remember, also very important when it comes to transitions of care, taking patients in, transitioning them from the ER to the ICU, resuming home antihypertensive sometimes can be also a very important intervention that a lot of us can do. It's also important for us to know what are some of the common medications that they will need in the PICSs within the ICU. So these are the medications that really should always be available for any place that's taking care of neurologically injured or post-stroke patients. The next big thing is seizure prophylaxis. This is a very interesting topic because I really enjoyed reviewing all the literature. And the more and more I review literature, the more evidence is coming up that really it's not recommended for most patients. And a lot of times what I see as a common practice is everyone's a little afraid to touch seizure prophylaxis because a patient's coming in with this neurological injury. Everyone's always a little afraid to touch a neurologically injured patient, and you don't want to complicate their care by removing a seizure medication that's going to prevent them from having a seizure, which is then going to further complicate things. I am going to make the case for quite the opposite. I'm going to make the case that giving seizure prophylaxis for someone who doesn't need it might actually be detrimental for their care, and I'll explain why. So overall, what's important to know is seizure prophylaxis. There's two types of seizures. There's early versus late. So early are defined as the first 7 days of injury, and late are defined after 7 days. Know that most evidence is really only available for early seizure prophylaxis. It's kind of like one of those things I like to use an example of anticoagulation and GI bleeding. So a lot of times with stress ulcer prophylaxis in the ICU, there was a question about, especially on the patients on the floor, not more so in the ICU, whether or not if you're on an anticoagulant therapy, whether you need to be on stress ulcer prophylaxis. And what showed is that those who are on anticoagulant therapy, adding stress ulcer prophylaxis didn't necessarily add any benefit. Those that were going to bleed were going to end up bleeding. So a lot of times we want to be cautious, but I think it's very important for us to know who specifically has an evidence-based indication, and how long it's important for. How long do we need it? It's important to know that seizures can occur for both hemorrhagic and ischemic stroke, but really at this time, it's not really recommended for either one of these patient populations, especially when it comes to prophylaxis. Now, if someone's having a neurological injury and they end up having a seizure, that's a different thing, right? And even then, evidence is really limited based on what people do. And a lot of times people manage it based on whatever whatever their neurological team's protocol is. So let's first talk about prophylaxis. Really, at this time, seizure prophylaxis is only recommended in patients with moderate to severe traumatic brain injury. And that's defined as GCS, Glasgow Coma Scale, which is a scale they do to check whether or not how awake a patient is on presentation. And this really can be found in any of the ICU flow sheets. So moderate to severe traumatic brain injury with a presenting GCS score of less than 8 and no more than 7 days. And really that's it. So a lot of times anyone that comes in with TBI, traumatic brain injury, oh, patient had a fall, patient had a bleed, any kind of brain hemorrhage, any kind of subdural hemorrhage, they might end up on seizure prophylaxis. But really, the recommendation right now is only for moderate or severe traumatic brain injury. The most Another indication that was very common previously was anyone with subarachnoid hemorrhage, which is a hemorrhagic stroke itself. And really, right now, the recommendation is no seizure prophylaxis is recommended. And even for like the latest guidelines for severe traumatic brain injury, to the point where they have its own guidelines, just seizure prophylaxis for severe traumatic brain injury. Um, they say that you can or cannot give. If you choose not to give, it's not going to be immensely detrimental for the patient. But we know how it is a lot of times. Physicians want to do as much as they can, so most physicians are going to opt to give it to their moderate to severely ill, injured patients. How much do we want to give? And which one do we want to give? And again, if you really look at the language, it's quite interesting. They're talking about we typically use loading dose. And again, this is talking about personal experience, right? So if we're going to give it, the recommended agent is levetiracetam. And they want to give a loading dose, which is typically 15 milligram per kilogram. And after the loading dose, you want to follow it by the maintenance dose of 750 to 1000 milligram twice daily. And again, yes, patients with renal insufficiency will need renal adjustment. And this is the dose that was really tested for seizure prophylaxis. And this is the dose that has the most evidence when it comes to preventing seizures, especially in traumatic brain injury or subarachnoid hemorrhage patients. So if we're going to give it, my biggest recommendation typically is if we're going to give it, let's give a dose to these patients that's going to be actually useful rather than just a placebo and not helpful. And why levetiracetam is preferred is that they looked at phenytoin, which is our traditional agent, and it was shown that phenytoin had a lot of adverse effect and even worse functional outcomes. So if we're going to give it, let's give a good dose. And they even talk about it right in the guidelines is that the higher maintenance dose is suggested because of the terminal half-life of levetiracetam is shorter in critically ill patients, leading to a more rapid drug metabolism and systemic clearance. Um, so that's just one point that I wanted to bring. Post-stroke seizure management. So if you have a stroke, if you have a seizure after a stroke, there's limited clinical evidence. How we decide what to do with these patients or how do services decide what to do with these patients. It's important to remember whether it was one episode versus multiple episodes. And a lot of times, most experts, where they actually just agree, the only thing they agree on is that if they're going to give something, they recommend giving just one anti-epileptic. A lot of times they recommend that for one episode, it might be okay to discontinue on discharge. If it's more than one episode, they might give it for 1 to 3 months. So typically for our part of our discharge plan, a lot of times we say, follow up with the neurological clinic, follow up with the surgical clinic, and at that time they can decide. Just FYI, if they do have a late onset seizure, so that's anytime after 7 days, so not when they had the initial insults, but anytime after that, they may have lifelong anti-epileptics. So although, we're pharmacists and all the times we may be on the teams or if we're talking about transitions of care, and that's where we're involved in taking care of some of these neurologically injured patients, it's important to ask these questions. Hey, are we continuing this? Are we not? And again, our recommendation, because of lack of evidence in this area, doesn't necessarily have to be, let's discontinue it, let's start it. Perhaps where pharmacists need to be is really asking the question, what is the plan? Because it's incredibly important for these patients for us to advocate for these patients because it is associated with worse recovery. So the first study that I have, it is anecdotal and it's quite old, but it is to understand that a lot of times they were talking about common drugs, but a lot of them were anti-epileptic drugs. So a lot of these patients would end up on anti-epileptic drugs after the stroke, and they do influence their recovery in the rehab. And most recently, what they looked at is phenytoin exposure and looking at the phenytoin burden. And this is really only 7 or 14 days, not more than that. We're talking about just 2 weeks of therapy and whether or not it was associated with worse functional and cognitive disability after subarachnoid hemorrhage, which is probably why, as you can imagine, the guidelines are no longer recommending giving seizure prophylaxis for subarachnoid hemorrhage. Just specifically, phenytoin was associated with worse functional outcome at 14 days, although that evidence was not really seen at 30 days. But then again, some evidence that even like a drug exposure of 7 to 14 days can have an influence on your outcome. It is important for us to continue to be advocates for our patients, especially when it comes to prophylactic therapy that might not be useful for them. The next thing I wanted to talk about is hypertonic saline. It's also another subject that I commonly see pharmacists not be too comfortable with. So I kind of wanted to just go over what is known and what is commonly not known. And I kind of wanted to debunk some myths. Know that hypertonic saline can be used as a bolus. So you can give it as a bolus of 50 cc's, 100, 150, 200, however you want it, or it can be given as a continuous infusion. And a lot of times people are asking me, it's like, oh, well, how do we start? What do we do? Really, oftentimes it's 3 to 5 milliliters per kilogram, and that's how you kind of just start. Know that anyone who is on hypertonic saline should probably at least be receiving a BMP or sodium every 6 hours, and we kind of titrate the hypertonic saline based on the response that patient's having, because each patient can vary based on their own personal responses and own regulatory hormones. It comes in various concentrations. It's important to know what your hospital's formulary is. Know that 1.5 up to 1.5 can be given peripherally, but up to 2% can be given peripherally, but anything higher than that, you do need a central line because of the risk of extravasation. The highest concentration is the 30 ml bolus that's available. It should be available, I would say, as an emergent medication in any of the neurological ICUs or in any of the ICUs where you may need to care for neurologically injured patients, because it's a medical emergency. And a lot of times, some of the hospitals also have as a herniation kit, and they make it as part of the herniation kit. So some hospitals choose to have a herniation code, and have a code cart. And with that, they would have like a brain code cart. And with that, they would just kind of have both mannitol and hypertonic saline as part of it. And some hospitals just choose to kind of keep it in their Pyxis. And other issues do become prominent with that, which is that, pharmacists probably need to verify this medication before anyone can take it out of the Pyxis. Just know that it's a volume expander and it can worsen heart failure. I wanted to sort of provide the emergency neurological life support pharmacotherapy chapter as a reference. It's a great resource for anyone to have. And it talks about the different concentrations that are available and how to start. And again, you can start anywhere from 2 to 5 milliliters per kilogram, but that's sort of like how you start. And you kind of move forward with that. And I have listed, I don't personally deal with any of the pediatric patients, but I do have the pediatric considerations included in this slide. The next thing is mannitol. So mannitol is also used frequently for neurological emergencies. Its dose is 0.5 to 1 gram per kilogram. And I wanted to share some pearls when it comes to administration of mannitol. So it's always important to remember that mannitol requires an inline filter. It can precipitate with crystal formulation, and it may require warming to dissolve crystals before administration. Nurses that use it, though, are quite familiar with how to use it. So, but it's important for us to kind of just review it always, of course. It can be given via peripheral access. So unlike hypertonic saline, for which above 3% you require a central line access, it's not an issue when it comes to mannitol. The duration of effect can be anywhere from an hour and a half to 6 hours. So you will see that. And it's really a diuretic as well, right? So you'll get to see the effect at least the first 2 hours. The patient, once you give it, the patient can put out as much as 500 cc of urine an hour. But a new concept that's really coming about is that uh, that I want all of us to be familiar with this evening is that we should monitor the trough osmolar gap. So what is a trough osmolar gap? So a trough osmolar gap, let's say you're giving someone a mannitol every 6 hours. So the recommendation is to get, let's say they're getting it at 12 a.m. to get a level of a serum osmolarity level for the patient right at that time. Now, how feasible it is in your hospital, I mean, again, it varies. I know for my hospital, it's certainly not. It can take up to 2 hours just for a lab result to come back, but perhaps in your hospital, it is feasible to get it right at that time and get the result in time. And the recommendation is as long as the osmolar gap is less than 20, you're able to give the medication. So the concern with mannitol is that it does cross the blood-brain barrier. So you need to continue to monitor serum osmolarity because if the osmolarity is too high, the concern is that when you give mannitol that it's going to go into the brain and actually worsen brain edema and not really help you. So how do you figure out the osmolar gap? So the osmolar gap is a measured serum osmolarity minus the calculated osmolarity. And a lot of times what traditionally we also do is look at just the serum osmolarity, and as long as it's above 310, 315, 325, everyone has their own threshold. They tend not to give it. But really the idea is that we really should be looking at the trough osmolar gap, and as long as it's less than 20, we should be able to give it. Again, the pearl is that it should be drawn as a trough. And then plasma osmolarity of greater than 320 is not a contraindication for ongoing administration. And a lot of times, some of these patients that really can benefit from an additional dose of mannitol can end up not receiving the therapy. And we'll see that in the example that I'm going to give you guys in a little bit. So again, an osmolar gap of greater than 20, if it's more than 20, the idea is that there is incomplete drug clearance between the doses and increased risk of the reverse osmotic shift, worsening the cerebral edema, and even nephrotoxicity. So the clinical big pearl here today is that it's okay to administer mannitol with the osmolar gap of less than 20, and we are going to practice that with a patient case. So overall, our patient case, 32-year-old male who was admitted to the ICU post-traumatic brain injury. The patient did receive 2 doses of mannitol in the past 24 hours. And now we have a new stat dose of mannitol 1 gram per kilogram times 1 dose. I've listed the laboratory parameters here, and what I want us to figure out is whether or not it's okay for us to administer an additional dose of mannitol. So here I listed the formulas again for you so you guys can all see. So first in the chat, why don't we figure out what the osmolar gap is for the patient? So we have the serum osmolarity listed here. Why don't we start with calculating the actual calculated osmolarity for this patient using the formula? And whenever you're ready, if you can put it in the chat, what you are getting for the calculated osmolarity. But whichever brave soul wants to put that in. So the calculated osmolarity is 2 times the sodium. Sorry, I think there needs to be a parenthesis here that's missing. So 2 times the, yeah, exactly. 2 times the sodium plus glucose divided by 18 and BUN divided by 2.8. So Hugh, I hope I'm saying your name right, has 328. Anyone else has that number? That's the number I have as well, 328. So based on that, let's now take it to the next step, which is calculating the osmolarity gap. So the measured osmolarity is 341 minus the calculated osmolarity, 328.8, or 329. What is the osmolarity gap for this patient? Exactly. I'm getting 13 or 12. Great. Now, is that less than 20? Yeah. So let's move on to our next question, which is, can this patient receive an additional dose of mannitol? And that's, of course, based on our osmolarity gap, which is 13, which is less than the threshold that we discussed. So most of you said yes. And I would say yes as well, because it's based on the trough osmolarity gap. So again, if you look at just specifically the osmolarity itself, 341, it seems really high. Typically, clinicians use osmolarity of greater than 320. As a threshold for not giving it. But if you calculate the osmolarity gap, and as long as it's less than 20, you can still give it. This patient technically still qualifies for that. Okay. So the next part, I'm really reviewing it overall, because we do see a lot of obesity in the ICU. So let's talk about having seen our obese patients in the ICU and how does it work. So obesity defined in America specifically is BMI greater than 30 kilograms per meter square. And the latest, which I just looked at, the data from August 2021 to August 2023, about 40% of Americans would qualify in this class. And as you can imagine, those patients who do get sick, out of the people who are obese, those are the people that are more likely to get sick. So that's the patient population that we are also more likely to see. But of course, but I also wanted to bring about another number, which is severe obesity, defined as greater than, sorry, not, I think there's a typo in there, greater than 40. About 10% of Americans are also in that. So as you can imagine, that there's probably a fair amount of severely obese patients that we might also see in the ICU. Now, what are the consequences of incorrect dosing in the ICU? I do have the reference list listed here. I would say that this is probably one of the great reviews that I've found specifically for ICU medications. It does a good job in overall looking at the classes of drugs and how to dose them specifically in obese patients in the ICU. So first, drug dosing inappropriately using the TBW or the total body weight. You can give a much higher dose for the patient. It might have minimal distribution into the peripheral compartments and have a super therapeutic concentration in the plasma compartment, and really that puts the patient at risk for increased adverse effect. Now, there are also some drugs that are used based on ideal body weight, but drug inappropriately being dosed using ideal body weight, you can administer the dose to the patient, perhaps extensive distribution into the periphery, and those patients can be at risk for subtherapeutic concentrations, and those patients are at risk for treatment failure. So it's important for us to know how to manage these patients on either side, so they really do stay in this level of therapeutic range with minimal adverse effects and also good drug dosing. I wanted to go over, just FYI, what are some of the commonly used equations for weight and drug dosing in the ICU. So a lot of times, I know this is true for my hospital, we actually automatically have BMI calculated for a lot of our patients. So BMI is total body weight divided by height in meters square. And we all, as pharmacists, we are well familiar with the ideal body weight equation, especially because we also need to use that for calculation of creatinine clearance. Some drugs are dosed based on lean body weight, but I really don't deal with a lot of those. But know that we also have this additional formula of adjusted body weight, which is the correction factor, added to the difference between the ideal body weight and total body weight. And a lot of times that correction factor is about 0.4. So what are some of the medication for pearls for these patients? So when it comes to vasopressors, the authors didn't have a lot to add. Why? Because, well, although some vasopressors, and this was a conflict in my ICU a while ago, whether we're going to dose norepinephrine micrograms per kilogram or micrograms per minute. Is it a weight-based medication? Is it not a weight-based medication? The whole thing is that like really the most important part here is to make sure that you have the accurate weight for the patient at all times, because it can fluctuate in the ICU quite a bit. So if whenever we're using smart pumps, it's very important to make sure that we have those correct weights, that the nurse is updating them, and we kind of bring that up to the attention of the nurse. A lot of times we can just call the nurses up to also update the patient's weight. And what they're recommending here is that for a lot of these patients, because vasopressor, you can see the response to blood pressure, and it's a drug dosing response. They don't recommend any changes specifically for obese patients because if anything, if they're not responding to it, we're just going to end up giving them the higher dose. And whenever you're maxed out for these vasopressors. So no adjustment recommended for a lot of these vasopressors. When it comes to corticosteroids, corticosteroid adjustment is based on indication. So for community-acquired pneumonia and shock, hydrocortisone is typically given less than up to 400 milligrams a day. So the authors recommend to kind of continue giving that medication, whether you want to give it 100 milligrams TID, or continuous infusion as recommended by some of the shock guidelines. They don't recommend any adjustment for community-acquired pneumonia and shock indication. Where they do recommend using an ideal body weight or adjusted body weight instead of actual body weight is when we're using methylprednisolone for acute respiratory distress syndrome. So because why that is because at that time when we're using methylprednisolone specifically, it's a weight-based dosing. And as you can imagine, these patients are at risk for receiving a really high dose. When it comes to stress ulcer prophylaxis, the authors again are recommending no adjustment to these medications. Currently, there's no evidence suggesting that we do need adjustment. When it comes to thromboembolism prophylaxis, it does matter what your BMI is. So I work in a trauma ICU, so most of my patients end up getting 30 milligrams twice a day, especially when it comes to enoxaparin. I'm specifically just talking about low molecular weight heparin. Here, the authors are recommending that for patients with BMI greater than 40, you should consider giving them 40 milligrams twice a day. And anyone above 50, you might even want to consider a weight-based 0.4 to 0.5 milligram per kilogram twice daily. So again, VTE prophylaxis highly dependent specifically whether it's severe obesity or BMI greater than 50. Some hospitals do have this. For some hospitals do still have a recommendation of getting an anti-10A level. So if your hospital does follow that, that's also something that's recommended. And again, those levels are specific for prophylaxis. When it comes to heparin, you don't have to consider increasing the dose up to 7,500. So instead of 5,000 Q8 hours, 7,500 Q8. And you don't have to consider that until you hit BMI of greater than 50. So obese patients really 30, we're not really necessarily concerned with prophylaxis, but really anyone with severe obesity, so greater than 40, or anyone with greater than 50, we might want to consider changes. So these are some things that we might even want to consider for a specific hospital DVT prophylaxis protocols. And last but not least, any of our patients with substance abuse disorder. I see quite a bit of these patients because in trauma, you don't get into an accident or you don't get hit by a car as a passenger or as a pedestrian a lot of times unless you're sort of on some sort of substance. So substance use disorder has a significant impact on critical illness and post-ICU outcomes. Types of substance abuse use disorders, you can have alcohol withdrawal. So severe alcohol withdrawal, you always see that in the medical ICU. But know that a lot of these other ICUs, you can also see patients with alcohol withdrawal, especially if the patient is intubated and they're going through withdrawal, it can become even harder to detect. You can also have hallucinogen related disorder. You can also have cocaine withdrawal. And then, of course, because of the opioid epidemic, you can also have opioid withdrawal. First and foremost, it's important to get a complete medication history in order to identify substance abuse disorder in the ICU. So what it presents with, so sometimes patients that are in the ICU that have mechanical ventilator, like their sedation is a little bit hard to manage. It's harder to get them off the mechanical ventilator. It's harder to reduce their sedation. And a lot of times patients and family members are not really forthcoming when it comes to substance abuse disorder. So it's important to know how to talk to family members, and really start asking questions when we're having difficulty with sedation. And it's important to also use a non-judgmental approach. But it's also important to remember that families can be unaware of any sort of history of substance abuse. Urine toxicology is probably the best thing that's in our toolbox for us to understand. And generally it's recommended, especially when it comes to trauma patients, we get it for all of our patients that are presenting. But number one thing is to consider detailed history of signs, and if you do see some signs and symptoms of withdrawal. And what are some of these signs and symptoms of withdrawal? I just kind of wanted to bring that up. So when it comes to alcohol, you'll see the typical tremor, sweating, severe anxiety, confusion, and more serious effects as seizures, or delirium tremens. When it comes to opioids, you can have diarrhea, vomiting, insomnia, muscle and joint pain, anxiety, and dysphoria. Cocaine, we see a lot of the fatigue, vivid dreams, sleep disturbances. And again, this is not gonna be something that's commonly seen in ICU patients. A lot of times it's masked with the primary disease that they have. MDMA, you will see serotonin depletion, depressed mood, and fatigue. I have the reference listed there for you. So they were also talking about how MDMA withdrawal is not necessarily it doesn't necessarily have severe symptoms. Same thing with synthetic cannabinoids and synthetic cathones. Synthetic cannabinoids, that's different than regular cannabinoids in a sense that they can have some of this like anxiety, tachycardia, and hypertension. But a lot of times, most of these go undetected. And mostly you'll be able to perhaps detect either cocaine withdrawal or alcohol withdrawal along with what opioid presents with opioid use disorder. So we're going to go briefly into the opioid use disorder and how to manage it. So when it comes to pain management in patients with opioid use disorder, there are a few misconceptions that can happen. First is medications that are used for opioid use disorder should cover the acute painful condition. So two common examples that I'm going to use are buprenorphine or methadone. So buprenorphine is a partial agonist and methadone is a full opioid agonist. And a lot of times people can think that, oh, they're already on something for this chronic use and it should cover it, but we need to manage their acute painful condition, post-acute, post-surgery condition, just like we would manage any other patient, because anyone that requires opioids after surgery is someone that's not requiring it before surgery, right? So it's going to be the same for those patients. Other misconceptions is that pain medications may result in relapse. It is always a concern, but one thing that I do try to remind my providers is that untreated pain is really more likely to cause a relapse, right? Anytime you have untreated pain that leads to chronic pain, that is always more of a problem rather than anything else. Other misconceptions, so adding opioids would likely result in CNS or respiratory depression, which is also not true. You can actually give them both an agonist and antagonist or partial agonist, and then complaints of pain may constitute drug-seeking behavior. And I'm not going to lie, I have seen drug-seeking behavior in some of these patients that have a history of opioid use disorder, and it can be really hard to decipher their true pain versus not. But I would still go with, like, I work practice primarily in the surgical ICU. So I would go with really honestly understanding the procedures that someone had and how painful, how likely you're expected to experience pain after that procedure. And a good example I like to use is that a lot of times after brain surgery, you shouldn't need a lot of opioids, right? Even though they're going into your brain, cutting your skull, right? Most of the time with brain surgery, they don't necessarily need a lot of opioids after, even if it's craniectomy, craniotomy, any of those things. However, a small lesion in the lung for a chest tube placement, anytime you breathe, you're expanding your lungs. Anytime you breathe, it's a painful procedure. And again, that's like up to 20 times in a minute, right? So anytime you have a small lesion, small cut for placing a chest tube, those patients are probably going to require a higher dose of opioids and opioids around the clock. So knowing the procedure and relating that based on patient's need, it's probably going to be the one thing that it's going to help you decipher drug-seeking behavior versus not. But I will say, even after 12 to 13 years, in clinical service, I still have a hard time deciphering that, especially in someone with opioid use disorder. But if I choose, again, we all are practitioners and we all have a preference, I always choose to treat pain. Other things I wanted to kind of bring up to attention is management of patients with buprenorphine maintenance therapy. So what if someone's on Suboxone or someone's on this medication, the extended release treatment, and how do we continue this therapy while they're in it? Well, there's multiple ways that you can manage it, and not one approach is better than the other, but these are just some of the ways that you can manage it. First approach is that you can discontinue buprenorphine therapy during acute care, and you can just manage their pain. And once they're done with their acute phase of pain, you can restart their buprenorphine therapy. You can also transition to methadone. That can also become controversial because not everybody likes to start methadone in an inpatient treatment. Not everybody's allowed to start methadone. There's a lot of state laws that can come into it. So, but transitioning to methadone is an option. Why that is why there's a difference. It's important to remember that buprenorphine has a high affinity for mu opioid agonist. So it has a higher affinity to bind to the receptor than even morphine, right? Even though it's a partial agonist, it can actually occupy the space that morphine's supposed to occupy. So although you can, for a little while, change to short-acting buprenorphine and add additional opioids, sometimes clinicians like a more cleaner transition. So either they'll choose to go to methadone or discontinue therapy. And after their management of acute phase, which is anywhere from 3 to 4 days, they will restart their buprenorphine therapy. Changing to short-acting buprenorphine therapy or keeping maintenance therapy and adding short-acting opioids is always an option. Whichever approach you choose to go with for your patient, just know, like, at this time, we don't really have a lot of evidence as to what's better. If you are going to use buprenorphine, just know not to use the extended release, to use the immediate release, change it to short-acting, and then use short-acting opioids, or just kind of discontinue therapy entirely. So overall, in conclusion, so evidence for special populations such as neurologically injured patients, obese, and those with a substance use disorder patient population is always evolving, specifically when it comes to seizure prophylaxis. Pharmacists and technicians should review key interventions for prevention of complication in these special patient population. And we are the key players for ensuring time delivery of critical medications in these patients. So with that, I'm going to end my presentation, and I will take any questions that you guys might have.
We do have a question for VTE prophylaxis and very low body weight, less than 40 kgs, or a BMI less than or equal to 18. Do you recommend weight-based enoxaparin or heparin?
So in those patients, I don't necessarily recommend weight-based. I would go with the more conservative approach of using 30 milligrams once a day instead of 40 milligrams once a day, and really just monitoring the anti-10A level in those patients. But then again, I also only deal with adult patients. So most of my patients tend to do okay with 30. I can't speak for pediatric patients. I also want everyone to know that in case you think of a question later, please feel free to email the question. You can submit your you can submit your questions by email, and I'll be able to respond to them, and you'll get that along with the CE codes or the survey that comes out for the CE.
Okay, thanks, Dr. Shafeeq. At this time, like she said, if you have any other questions and you'd like to ask them later or in private, please feel free to either email the office or her directly. And at this time, I'd like to introduce again Dr. Shah to present the next hour CE.
Hi, everyone. Are you able to see my screen and hear me? Okay, I will take that as a yes. We will go ahead and get started with the second part of our presentation. Thank you all for being here. We're going to take a little bit of a turn and talk about pediatric delirium in the intensive care unit specifically now. Okay. I have no relevant financial relations to report. And for our objectives for this evening, and what I hope you guys are able to gain by the end of the presentation, some ideas I'll be reviewing include reviewing our pathophysiology and risk factors for pediatric delirium, identifying causes and assessment tools to identify delirium in pediatric patients, going through some recommended non-pharmacologic and pharmacologic treatment options in pediatric patients. And then lastly, going through and considering our barriers that we encountered and currently do still encounter in managing delirium in our pediatric patients. So I did want to go through a quick timeline on how pediatric delirium came about, how it developed, because we are seeing and talking about it more and seeing it more in practice, but it actually really first originated in the 1980s. There was a case series that was published by Prague and colleagues in 1980 that discussed a total or included a total of 33 children and adolescent patients that had some sort of CNS complication that included basically metabolic changes and some sort of trauma. And they compared those to patients to a match cohort that did not include those. They compared them during the acute phase and also off the acute phase. And what they found was that the findings are actually very similar to what they noted in adult patients in adult delirium. And then 23 years later, almost 2 decades, a little over 2 decades, there was the first diagnostic study that was published by Turkle and Travare in 2003. In this, they just described the presentation, symptoms, the overall outcomes that were noted in pediatric delirium. And they found that they were very similar to the Diagnostic and Statistic Manual of Mental Disorders, the criteria listed in that. And then in 2005, we had our first other clinical trials being published by Sheffield and colleagues. They continued up until 2009. And then finally in 2022, we had our clinical guidelines published by SCCM, the PENDEM guidelines. And so basically, what is delirium? It's an overall form or change of an acute brain dysfunction. The DSM-5 and the World Health Organization describe it as a disturbance in attention, awareness, and overall changes in cognition, emotion, as well as alterations in your sleep-wake cycle and overall perception. All patients are at risk for developing delirium that are hospitalized. The range is anywhere from 12 to 65 in just overall hospitalized pediatric patients, but this can really also go up to 30% specifically in our pediatric patients in the ICU, in the PICU. There are a few components that contribute to the pathophysiology. There is a change in an overall neuroinflammation change, a neurotransmitter change, and then oxidative stress. So the neuroinflammation really occurs from a change in systemic inflammation. And then this leads to a production in inflammatory markers that can lead to local ischemia as well as neuronal apoptosis. There is changes at the neurotransmitter level, which allows changes in receptors and neurotransmitters from the medications that we're giving our patients. This includes changes in acetylcholine, serotonin, GABA, so on and so forth with all of the medications we're giving them. And lastly, there's an oxidative stress component. So due to a reduction in oxygen delivery, there's increased cerebral metabolism, and then there is an increased production of oxygen species. There are several risk factors that we should account for when looking at and diagnosing delirium. So certain patients that have some risk factors such as baseline developmental delay are at higher risk. Patients that are of younger age, so less than 5, but also those less than 2 years of age are even more at risk of developing delirium. There is a positive correlation for patients that have a increased severity of illness on presentation, or if they develop one throughout their stay, then they're at higher risk of also developing delirium. Patients that are invasively ventilated, mechanically ventilated, are at higher risk. This correlates with the amounts of sedation we're giving them, and it kind of becomes a cycle. The overall length of stay, so if patients are admitted to the ICU for more than 5 days, that is a risk factor in itself. And then lastly, medications. So the medications we're giving them, benzodiazepines are the most notorious ones. And then there's also anticholinergics and other medications. So looking at our causes for delirium, there is an acronym to help remember the causes. It's IWATCH death. It's a little unpleasant, but it does help us remember what to look out for when we're looking for causes of delirium. So for eye, infections is a big cause. This includes infections anywhere, whether it be a UTI, a pneumonia, or meningitis, withdrawal from medications. So it could be from withdrawal from alcohol, any barbiturates, benzodiazepines themselves, any changes in acute metabolism. So any changes in electrolyte imbalances, acidosis, trauma in itself. So if there's direct head trauma or if the patient is post-op, any changes in CNS pathology. So if the patient presents with a stroke, if they have a hemorrhage, or they're presenting with status epilepticus. Hypoxemia, so any patients that have any level of cardiac failure, or if they present with a pulmonary embolism. Deficiencies in vitamins such as B12, folic acid, thiamine. Any changes in endocrinopathies. So if they come in with adrenal insufficiency, any acute vascular changes. So if they come in with septic shock, which is commonly seen in the ICU setting, any toxic or drug changes. So if they have a toxic ingestion, substance intoxication, and then heavy metals, which is a little less commonly seen, but any ingestions of lead or mercury. In terms of looking for causes for delirium, so another way that we can look for causes, but also assessment and evaluation and management is brain maps. So bringing or delivering oxygen to patients that have any hypoxemia, removing that offending drug or agent that's causing delirium. So if we're giving them anticholinergics or benzodiazepines, discontinuing it if it's possible, setting up the room appropriately, the atmosphere, making sure our family is around. The infection part that we talked about, treating that infection, looking at any new organ dysfunction that is developing or worsening and addressing that. Again, any changes in metabolic disturbances, so normalizing our electrolytes, that sleep-wake cycle that might be altered, and establishing a day-night routine. And then lastly, any pain or sedation that is under or overtreated. So setting a sedation target, using our validated scoring tools, and then optimizing their pain control to make sure that their pain is properly treated as well. There are two main types of delirium, hyperactive and then hypoactive, and then there's also a mixed type that fluctuates between the two of them. So hyperactive consists of signs of agitation, of restlessness. They might have combative behavior. So these are the patients that we'll likely see being in restraints, unfortunately. And then hypoactive consists of signs of lethargy and attention, and then overall decreased responsiveness. So in pediatrics, hypoactive is the more concerning one, and it is correlated with the poorest prognosis. But compared to adults, delirium is also just more subtle to diagnose in pediatrics. And that's due to the fact that they're still developmentally developing, right? There's so much developmental variability in them compared to adults. So it is a little difficult to differentiate compared to our adult patients. Now, when looking at consequences of delirium, so even though it's a temporary state, these effects are persistent and can have long-term effects. For patients, some things that can occur would be having an increased hospital length of stay, unfortunately, an increased length of PICU stay. Increased overall length of mechanical ventilation can go up if patients develop delirium. And in relation to that, safety events as well. The patients are at higher risk of self-extubating, removing their NG tube or OG tube or their lines. So unfortunately, this also leads to them using more restraints and more sedation. And again, this becomes that cycle that you're maybe oversedating them, not managing their delirium, not seeing their delirium, and then leading to more sedation. And then lastly, overall morbidity and mortality is also much higher in these patients compared to those that don't develop delirium. Looking at long-term effects, once they leave the hospital or once they're on the floors, we also see changes in baseline neurodevelopmental complications. Because these patients are younger, they are still forming their neuronal synapses and transmitters. So a lot of times, if this happens at a much younger age, they may also have long-term behavioral consequences. And then overall quality of life, when comparing our pediatric patients that have delirium to those that have not, there is an overall lower quality of life compared to the healthier children. So in 2022, the SCCM I mentioned did publish our first guidelines in managing pediatric delirium. They were titled the Clinical Practice Guidelines on Prevention and Management of Pain, Agitation, Neuromuscular Blockade, and Delirium in Critically Ill Pediatric Patients, with consideration of the ICU environment and early mobility. It's a mouthful, but we can call them PANDEM. Till these were published, we had really no guidelines for managing delirium. Compared to adult patients, their first guidelines came out in 2013, and they even had a revision in 2018. So we were definitely lagging behind the adults. And in the guidelines, the team did put together a few strong recommendations and then a few conditional recommendations. So they did strongly recommend what assessment tools to utilize for assessing delirium. They recommended the preschool and the pediatric confusion assessment methods for the ICU, as well as the Cornell assessment for pediatric delirium. They also recommended to use those tools on admission to the PICU, as well as upon or throughout their stay up until discharge or transfer. They also strongly recommended minimizing benzodiazepine use, as more literature has come out to show that they cause they are positively correlated with delirium in both adults and pediatrics. And then lastly, they recommended baseline EKG monitoring for patients started on any antipsychotics and then routinely throughout while they're on the antipsychotic. A few conditional recommendations included patients or encouraging patients to basically utilize non-pharmacologic strategies. So optimizing their sleep hygiene, making sure they have a schedule, incorporating family both on rounds and in the patient's care. They also had conditional recommendations on suggesting early mobilization when feasible. It's really shown to orient patients to, self-awareness. So early mobilization is a key component as well. And then a few other conditional recommendations were they did suggest overall minimizing sedation as feasible, as clinically feasible, and then also not routinely starting patients on any antipsychotics for the prevention of or to decrease duration of delirium. However, if patients are refractory and they have refractory delirium, then to consider starting them on an antipsychotic. Of note, which I found very interesting, because there's still data lacking in pediatrics, there was no recommendation on which antipsychotic to start. So we will talk about that in a little bit. So when we look at these assessment tools, there's two that are really validated in pediatrics. And there's two versions of one. So there's the pediatric and the preschool version of the CAM-ICU, which the CAM-ICU is utilized in the adult world. The PS CAM-ICU is used for patients 6 months to 5 years of age, and then the PCAM-ICU is used for patients greater than 5 years of age. There is a difference in some of the questions that the nurse or the assessor asks, so they did develop one for the younger pediatric patients. All in all, it is a two-step assessment and it does require patient cooperation. So it can be a little challenging to complete at the bedside if your patient is not able to cooperate. And the CAM-ICUs, whether it be the pediatric or the preschool, they both utilize the RASS, the Richmond Agitation Sedation Scale, which is the validated sedation scoring tool in adults, or the SBS, which is the State Behavioral Scale, which is a validated sedation scale used in pediatrics. The benefit of this assessment tool compared to the other one, which is the CAPD, is that it is a briefer assessment. There are only 4 parts. A patient would score positive for delirium if they were positive in parts 1 and 2, and then either 3 or 4. When looking at the CAPD, it's the same scoring tool utilized for all pediatric age ranges. And the score range is anywhere from 0 to 32, with 9, if you score 9 or higher, you would be considered positive for delirium. It is completed through observation, so it does not involve direct patient interaction and cooperation. So it is a little bit more feasible to use at the bedside. However, it is a longer assessment, and we'll go through both of these. So when looking at the PCAM-ICU or the PS CAM-ICU, the step 1 is the same for both. On the top left, you can see that the Richmond Agitation Sedation Scale is incorporated. And in the bottom right, you can see that the SBS score or scale is incorporated. So for patients that are too sedated, if they're -4 or -5 on the RASS scale, or if they're -2 or -3 on the SBS scale, we unfortunately would not be able to assess for delirium, and we'd have to end the score or end the assessment right there. However, if they're not as sedated, because there is direct cooperation involved, we would move on to the next step to assess if they're positive for delirium or not. So here you can see that there are 4 features to assess for delirium. The first feature is basically looking to see if there's any acute changes or fluctuating courses of mental status. If the assessor says yes, then you move on to the next feature. The next feature, which is feature 2, is assessing for inattention. Here is where there is direct cooperation with the patient. So the assessor will ask them to squeeze my hand when I say the letter A and some other commands. If the patient makes 3 or more errors, you would have to move on to the next step. However, if they are not positive in this area, then you would stop the assessment right then and there, since they would not be positive for delirium. So feature 3 is a yes or no again. Is there any altered level of consciousness? If yes, you move on to the next step. If no, you also move on to the next step, since there is still one more part left. And that part is looking for disorganized thinking. So the assessor may ask questions like, is sugar sweet? Is ice cream hot? And basically the patient would have to somehow respond, whether it be through a yes, no, whether it be through some sort of other way that they're able to communicate that they're understanding these questions. If they're positive here, they would be positive for delirium. And then when we look at the PS-CAM ICU and what the difference here compared to the PCAM ICU, the main difference is just feature 2, the part of inattention. So here you can't really ask them to squeeze your hand or not if they're 6 months of age. So instead we would show them pictures and have them try to organize their thoughts and attention by pointing to the correct picture if possible. This is why it gets challenging, because even then you still may not be able to perform these assessments. And then looking at the CAPD, you have the RAS score incorporated here, not the SBS score, which is the validated score in pediatrics. So again, if you're too sedated, so -4 or -5, you would not be able to proceed with the 8 questions that are on this tool. It is a Likert scale, so it is basically assessing anywhere from 0 to 4 based on the question that you're looking at. And it's an observational assessment. So some of the things the assessor would ask is, does the child make eye contact? Are their actions purposeful? Is the child aware of their surroundings? Are they able to communicate their needs and wants? Is the child restless? Is the child inconsolable? Are they underactive? Or are they taking a long time to respond to an interaction? And you can see how some of these can also still be challenging in some of our younger patients. And this is why it's much more of a harder diagnosis in pediatrics than in adults. Some preventative measures that we can take to make sure delirium does not develop in these patients, or to minimize their risk for developing delirium, include having a lot of some of these environmental modifications. So making sure their sleep-wake cycles are normalized. Are the lights on during the day and are they off during the night? Are we minimizing the number of times we go into the room at night? Are there quiet hours at night? That will basically help them reverse or fix their sleep-wake cycles if they are abnormal. Having family around. Is family involved in their care? Is family in the room with them? Are they holding their hand? Are they able to bring in things from home, like a blanket or a stuffed animal that makes it feel like this is their home, even though they're away from home? Looking at any pharmacologic optimization. So there's an approach, an analgesic first approach, that really helps prevent delirium. If we control their pain, we can help decrease their need for sedation. If their sedation requirements are lower and they're on lower sedatives, this would lead to less delirium. And then this would hopefully help us to assess their pain better. So this process is called an analgo sedation model. And having this at the bedside and applying this to our patients can really help minimize just overall sedation, but also optimize their pain. And then lastly, early mobilization. So early mobilization is really key in promoting their cognitive health and their physical health. So incorporating this when it's safe and feasible in our patients to help prevent delirium. And so now we'll move on to a polling question. Which of the following is not recommended to prevent pediatric ICU delirium? A, an analgesic first approach. B, delay mobilization. C, normal sleep-wake cycles. Or D, family caregiver involvement. I'll give you guys some time to think about that. Okay, so it looks like the majority of the group did say to delay mobilization. That is true. It's not recommended to delay mobilization. We should be having or promoting early mobilization. Perfect. Oh, yeah, to delay, not to delay mobilization. Before we jump into pharmacologic management, I did want to touch upon non-pharmacologic management, since this is important in preventing, or I'm sorry, in treating delirium before we start any medications. So we did talk about a lot of these factors, but just to touch upon them one more time, because not only do they help prevent delirium, but they also help to treat delirium. So if we address any underlying disease states that are causing delirium, looking for the infection, looking for any changes or causes that's leading to hypoxemia, correcting any metabolic abnormalities. These can help treat our patient's delirium as well, in addition to things such as things that we're causing. So the iatrogenic factors. Again, are we optimizing the patient's pain? Are we minimizing sedation when possible? And if we're in the part of weaning the patient's sedation or pain, are we managing any withdrawal? Are we preventing any withdrawal? And then the same environmental factors that we already talked about. So improving their sleep-wake cycle, having that early mobilization, decreasing any stimulation that we can, and then always having parents around or caregivers around when we can. However, when all of that fails and patients have refractory delirium, we would need to consider pharmacologic treatment. So there are several agents used, and there's even a few that are not even listed on the slide. So quetiapine, risperidone, olanzapine, aripiprazole, which is really not that strongly or highly used, and then melatonin as well. So two agents that are not listed are haloperidol, which really has fallen out of favor for use in pediatrics. So I won't even be talking about it. And then dexmedetomidine infusions. So the data there really is for our post-op patients coming out of anesthesia for emergence delirium prevention. Not really shown yet in pediatrics for treating ICU delirium. There is some data in adults though, so hopefully to come in peds. So let's jump right into our medications. So quetiapine. This is one of the more common agents used to treat pediatric delirium. And this was a case series that was published in 2013 by Traub and colleagues. It consisted of 4 patients. There were patients ranging from 8 months to 14 years of age, and the underlying diagnosis ranged in these 4 patients. One patient had PCP pneumonia, the other one had an aortic correction, the third patient had a fungal pneumonia, and then the 4th patient had a craniotomy. However, 2 of the 4 patients were on opioid infusions, as well as a dexmedetomidine infusion, and then midazolam or lorazepam. The starting doses were listed in 3 of the 4 studies as 1.5 mg per kg per day, and then some had them defined as divided Q8, but once case did not. The final dose was only listed in 1 of the cases, and that was up to 8 mg per kg per day. But overall, what the study found, and they did use RASS for sedation assessment, and they screened patients with the CAPD screening tool. Overall, what they found was a lower usage of both opioids and benzodiazepines in the 2 patients that were on them, and then an overall improvement in 24 to 48 hours in the patient's agitation, delirium, and just lower delirium scores. There were 2 more recent studies looking at quetiapine for delirium management. One was published in 2023. This was a study that looked to evaluate quetiapine efficacy for treatment of delirium in critically ill pediatric patients and to describe its safety profile. This was a single center study. It was also retrospective. It was conducted at NYU. Patients less than 18 years of age were included, and those that scored a CAPD score of 9 or higher were included. And they had to be on quetiapine for more than or equal to 48 hours. What the study found overall was there was a 68% decrease in opioid use and 43% decrease in benzo use. The median CAPD score only went down by 1 point at the 48-hour mark from 17 to 16. And not all patients were routinely monitored for QTC prolongation, but 3 patients did experience QTC prolongation. So the study found that the appropriate dose does really need to still be studied to have a more appropriate and effective an effect on decreasing opioid and benzo use, since this was not shown to be significant. But they found that the safety profile was good for quetiapine. The second study was published in 2024, so it's a little bit more recent, and it looked to investigate the short-term effects of quetiapine on opioid and benzo requirements and any associated adverse events. This was a single-center retrospective study as well, that took place only in the cardiac intensive care unit. There was a 72-hour pre and post quetiapine initiation analysis, and basically only 13 patients were included. There was a significant reduction in opioid and benzo use that was noted, excuse me, as well as a significant reduction in the number of PRNs used as well. The study did find that there was no significant effect on quetiapine on QTC interval. And so all in all, the study found that not only was quetiapine safe, but also effective in significantly reducing the opioid and benzo usage. Another agent that's commonly used in pediatric delirium is risperidone. So this was a study that described the dosing safety describe the dosing, safety, and tolerability of risperidone for ICU delirium in patients less than 2 years of age. This was also a retrospective descriptive study where 17 patients were included that had received at least 1 dose of risperidone. So this could mean that these patients were not all in steady state, since to be included, they only had potentially just 1 dose. The initial daily dose did range from 0.1 to 0.25 milligrams, and a majority of them were on once daily dosing. A majority of patients also required a dose increase during their course, and the max dose ranged up to 0.5 milligrams. The study found that there was no change in sedation requirements, and not all patients were routinely again screened for EKGs or with EKGs for QTC prolongation. And then only 3 patients were scored for CAPD. So here you can see that there's such great variability, not only for monitoring for delirium, but also continuing to monitor after an agent is started to treat delirium. And that kind of highlights some of the improvements that we still have to work on in managing pediatric delirium. Another agent that is not routinely used, but we have used it at CHAM a few times, more so for patients that are MPO, since we do have the ODT formulation of olanzapine on formulary. It's really helpful in those patients that we are that are MPO and we're not able to give anything even through an NG tube. So this was a study that looked to determine the efficacy of olanzapine for the management of pediatric delirium. It was a retrospective longitudinal study that compared olanzapine to a control group. And the dosing is listed there for you, but the dosing differed based on whether the patient was an infant, a toddler, or an adolescent. 59 patients were included, 31 to the olanzapine group and 28 to the control group. But the study, of note, the study did use the DRS, or the Delirium Rating Scale, which is a different assessment tool compared to the CAM-ICU or the CAPD scoring tool to assess delirium. It's fallen out of favor. So that was one of, I guess, the limitations to the study. The study group that was included of the olanzapine group did have more severe symptoms of delirium at baseline. And they also found a greater improvement in symptoms in that study group versus the control group. And the overall study did notice that there was no significant adverse effects noticed. They studied EPS, EKG changes, including QTC prolongation, and then any changes in any of those effects. Sorry. The last drug that I want to talk about is melatonin. I feel like Immunocham, we have started using it a lot more than we used to when I first started at my practice site. The reason is that it really is more so used sometimes for preventing delirium or for, helping the patient fix their sleep-wake cycle. And I think the role is still yet to be determined for melatonin, but because it's such a benign drug, I feel as though most of us are not opposed to using it and starting it on our patients. So this was a study done to determine melatonin's role as either prophylaxis or a first line or second line treatment for delirium in the PICU. This was also a retrospective single center chart review. Patients were admitted if they were in the PICU for greater than 48 hours. Sedation was measured through the RASS score here, and they didn't specify how delirium was measured. 63 patients were included, of which 39 patients had antipsychotic use after melatonin was initiated. The most common antipsychotic that was prescribed or started was risperidone. There was no difference in sedation exposure in the pre versus post melatonin group. So the role again here, I think, is yet to be defined by melatonin or for melatonin. And there was a decrease, though, in the RASS score in the post versus pre melatonin group, but not shown to be significant. So the role really does need to be of melatonin for prophylaxis, needs to be further studied. And as we start these patients on antipsychotics, we're always trying to be mindful, especially in the ICU setting, concerns for QTC prolongation, since these patients can be on several agents that can prolong your QTC. So this was a study done to look and determine the incidence and risk factors for QTC interval prolongation in critically ill children treated with antipsychotics for ICU delirium. This was another retrospective chart review where 29 patients were included in the analysis. Of note, they only had to receive one dose of an antipsychotic to be included. Majority of the patients did receive risperidone, and then that was followed by haloperidol, which is only 2 patients, and then 1 patient each for quetiapine and olanzapine. There were no occurrences of arrhythmias noted in the study, but 2 patients did have QTC prolongation. Both patients were receiving risperidone and multiple other agents that can prolong your QTC. So I think that's the real concern that we have when we're starting these patients on antipsychotics. If they're already on another agent, it can be on Zofran or methadone or ciprofloxacin, and just being mindful of the number of agents that can put them at risk for QTC prolongation. This was a more recent study completed in the spring of 2024. It looked to determine the effect of either quetiapine or risperidone in not only treating delirium, but also looking at QTC prolongation effects in post-op cardiac patients, pediatric cardiac patients. This was a retrospective chart review again. 139 patients were included in the analysis, of which a majority received risperidone. So 115 received risperidone and 24 received quetiapine. There was no occurrence of arrhythmia that was noted in these patients, and no significant changes in QTC after either antipsychotic was started. The mean CAPG score did significantly decrease, and of note, quetiapine did have a greater improvement in delirium compared to risperidone. So I think that might be helpful in the institutions that have a pathway or are in the process of developing a protocolized approach to managing delirium in pediatrics, learning and figuring out which agent you would prefer to have as your first line, since I know a few institutions use quetiapine and some use risperidone, but all in all, when it comes to effects on QTC and arrhythmias, there does seem to be minimal concern when they're looking at that agent in silo. So now we will move on to our second polling question. Which of the following agents has the highest risk of causing QTC prolongation? A, haloperidol, B, quetiapine, C, risperidone, or D, olanzapine? Okay, it looks like the majority of the group did say haloperidol, which is correct. Due to its QTC prolongation effects, it has fallen out of favor and use in pediatrics. So most hospitals use either quetiapine or risperidone. The practice can vary based on which institution you're working at, but either one of those is usually our go-to first line agent, and then the alternative is the go-to second line agent. Now, when it comes to current practices, and I think this is a much bigger challenge that we experience in pediatrics compared to adults even, we often struggle with having a protocolized approach, having one agent as our first line for the institution, which scoring tool to use, how to educate and even screen for delirium, even with the validated screening tools. So this was a study done to look and describe how pediatric cardiac intensive care clinicians assess and manage delirium in patients following cardiac surgery. This was a web-based survey that was distributed to the members of the Pediatric Cardiac Intensive Care Society. 173 clinicians did respond from 13 countries. And overall, from those 173 clinicians, they determined or they reported that they only had a diagnosis of delirium in 25% of patients. So this is a little bit on the lower end. There are some more recent studies that say even up to 49%. But I think the bigger concerns that were noted in the study was that 75% reported that routine delirium screening did not occur. So that means they only routinely screened in a quarter of the patients or a quarter of the sites. And then of all the clinicians that responded, only 8 had a protocolized approach to assessing and managing delirium. So that's a huge room for improvement in pediatric delirium. The predominant scoring tools were either the PCAM ICU or the CAPD, which goes hand in hand with the recommendations of utilizing either of those, since they are the 2 validated tools in assessing delirium in pediatrics. And then lastly, antipsychotics. So if a patient was screened and positive and refractory, antipsychotics were not widely prescribed. But if they were, risperidone was the predominant agent. So I think all in all, the study from the clinician and attending aspect does highlight the lack of standardization in pediatrics. And then another study that was published more recently from the pharmacist perspective was this delirium assessment treatment strategies in critically ill pediatric patients, a Pediatric Pharmacy Association practice-based research network study. The purpose was to describe the screening, prevention, and treatment for pediatric delirium across NICUs, CICUs, and PICUs for those in or within the PPA membership. So again, this is from the pharmacist perspective. This was a cross-sectional questionnaire that was distributed to PPA members from February to March of 2022. And the primary objective in the study was to identify the number of respondents that had a defined delirium-based protocol. And secondary objectives included identifying which tool they used, what non-pharmacologic therapies and pharmacologic therapies they utilized, what their first line and second line agents for treatment were, and then their overall monitoring practices for delirium management. So of those that responded, only of those that received the survey, 84 responded across 62 sites. And from the 84, 61 respondents noted that their units routinely did screen for delirium. So that was a much higher amount and percentage compared to the previous study. It is about like 5 years later, so maybe there has been a little bit more awareness about this as well. From the respondents, 33 had stated that they had a defined delirium protocol. So about a third, which is again, much better than the 8% from the last study. And then the most common agents that were used were either quetiapine and or risperidone. Some institutions had one as their first line and then the other one as their second line. And then 74 respondents had stated that they monitor EKGs to assess QTC, but there was no set practice on how frequently, so it was wide variability. So all in all, I think, again, it just points to the lack of basically standardization in pediatrics for assessing, managing, and treating delirium. And then so that makes us wonder, what are the barriers? Why is it such a barrier in pediatrics to have a protocolized approach, to have appropriate screening completed and consistent screening completed and monitoring? So this was a study completed in 2019 that looked to evaluate the impacts and effects of implementing non-pharmacologic nursing bundles on the incidence of pediatric delirium. So again, the purpose was to implement these bundles in patients 2 to 18 years of age in the pediatric intensive care unit. They did plan to enroll the CAPD screening tool. What they found was that the CAPD screening tool was not built into their EHR. And a lot of these results actually are in alignment with what we experienced at CHAM a couple of years ago when we were enrolling our delirium bundle and our QI project to incorporate delirium in our care for our patients. They also found that standard screening times were not ideal with nursing workflow. There were difficulties understanding the screening for patients that were either intubated or were on sedation, or both, those that were of younger age, and then patients with developmental delay. And then lastly, if delirium was identified, there was a lack of trust in the medical team to treat the delirium. So a lot of these are in alignment with what we experienced at CHAM. We had our delirium pathway enrolled a couple years ago, but it took a solid maybe 2 years to be where we are now. And we're still learning as we go. So some of the barriers we had were educating all of our team members. This included not only the providers and nursing, but also pharmacy as well. Showing them what delirium is, going through the scoring tools, going through the limitations of the scoring tools so they are aware of those as well. Because those patients with developmental delay are still really challenging to assess for delirium. We did not have CAPD also built into our EPIC or our EHR. We had only the CAM ICU, but that was being utilized by the adults. So it took quite some time to build out the CAPD score into our EHR. And then CAPD is shown to be studied with the RAS score as a sedation tool. So we had to figure out how to swap that out with the SBS, since we use the SBS to assess sedation in our pediatric patients at CHAM. And then we did not have quetiapine built out into our EPIC system. Quetiapine oral solution, built out into our EPIC system. We only had tablets. So it was our first line agent that we recommended, but we couldn't give it to all patients because it only was built out as tablets. And then something that was a great help was incorporating the delirium bundle into our daily rounding safety checklist. So oftentimes we would round on patients and not even talk about delirium. So we put it in our checklist to make sure for each patient, at the end of rounds on each patient, we make sure we address delirium. We talked about their scores and that the scores are actually being done, and so that we can properly treat if needed. So looking at the pharmacologic management, this was a pathway that we put together. It is due for revision, so I'll point out the things we plan on revising. But basically, our first line agent was quetiapine due to its effects on low QTC prolongation. Risperidone was our second line agent. It does have some more QTC prolongation, although there seems to be some data saying that may not be the case, that it may be very similar to quetiapine in terms of QTC prolongation. And then olanzapine was a good alternative that we had because we do have ODT on formulary. Aripiprazole was added on based on our pediatric psychiatry recommendations. We do plan on taking it off of our recommendations because we don't use it. It has such a long half-life that it doesn't really make sense to start patients on aripiprazole. And then we plan on removing haloperidol, which we did have and do still have on our original pathway, since we don't use that in pediatrics as well anymore, not at CHAM at least. We also incorporated a dosing guideline for all of the providers, the nurses, and pharmacy on each drug, on the route, the available routes, the starting doses, how we can give PRNs, how many times a day we can give those PRNs, and then how to titrate up that maintenance dose, and then the max dose that we would suggest for those agents as well. And then looking at our CAPD screening tool, since this is built out with RAS, we basically just swapped it with the SBS score. If they're too sedated, we would not proceed, just like if you were too sedated on the RASS score. But the bigger challenge was not this, but more so incorporating it into our EHR. So I know the picture's a little blurry, but this is the CAM ICU that's built into our flow sheets. And we really had no way of documenting CAPDs. So we were paper documenting, and we would go around and ask our nurses if they, documented it on their nursing handoff, which is a paper sheet. So it got lost so many times up until we finally had it built out in our Epic flow sheets. And so here you can see that the CAPD score is in fact built out now. So it's become a much more smooth process. And we can also report it as a trend. So we had it built out into our patient scores, so we can trend it over 12, 24 hours just to see how their delirium scores are improving, worsening, or staying the same, and assess their therapies. So to conclude, pediatric delirium is a highly underrecognized and high-risk diagnosis. It can lead to so many complications, but I think the bigger concern is that we have such limited lack or standardized institutional protocols for assessing and managing delirium that can help improve overall outcomes, that I think that really should be our first step. And then hopefully with time, we have more studies that show, which agent is, more preferred and better at lowering delirium scores in pediatrics, because right now it's really just a whole bunch of retrospective studies. But it seems like risperidone and quetiapine are our go-to agents for delirium treatment. And at this time, I will take any questions. Thank you all.
Thanks, Dr. Shah. I do have one question.
Mhm.
With dealing with the pediatric population, depending on how old they are, do you find that you have family involvement or critiques a lot when it comes to some of managing delirium and agitation in this patient population?
I think it really depends on, unfortunately, the patient, what they presented with. I wouldn't say critique. I think most families are much more on board with the non-pharmacologic options. And they're the ones actually that are able to sometimes tell us better than even our own nurses and our providers, this is not my child. And so when we tell them or ask them, what is your child? What's different? And by then, hopefully, we've had enough scores and are able to trend them. But they're more than happy to start the non-pharmacologic management instead of starting any medications. And so it's always a good first step for us at CHAM that our parents are usually involved and are able to tell us when something is, not okay. In terms of critique for starting any medications, I think it really, again, depends on the family and how involved they are. There are some family that are not involved at all. But those that are involved, and we go through the reasoning for starting any agents and explain the risk versus benefit. I don't think we've ever had any opposition to start management if all else has failed.
Great, thank you. I'll give a couple more seconds in case anybody wants to ask a question in the chat. Otherwise, like Dr. Shah said, please feel free to either email herself or you can email the office and we can always forward the email. All right, so I think we can wrap up today's program. Again, thank you so much, Dr. Shah and Dr. Shafeeq, for providing today's webinar.